Welcome, everyone. This is Mike on Diaz, yes. My name is Skip Rutherford, and I am Dean of the University of Arkansas Clinton School of Public Service. And let me introduce to you who just walked in, no stranger to Arkansas, the founding Dean of the Clinton School of Public Service, Senator David Pryor. Stand up, DP. On behalf of the students, faculty, and staff, we welcome you to this community conversation. It is amazing what a great speaker and a great topic will do for a crowd, so we are honored to have you here. Our students are not here tonight. They are on their international internships. And before you leave, take a look at the map at the back of the room to see where they are. Certainly of interest to us is this virus and its impact on the countries where our students are now working. So this topic is both timely and personal, and we are glad to have you here. We will be announcing our new class in early August, and we'll also be announcing our distinguished visitor public programming schedule, which I think you all will like and enjoy. I hope, like our email system where people can respond and come to these events, get used to more because we've got a lot coming this fall. And coordinating that activity is a young man who is a graduate of the University of Nebraska and a pretty fair tennis player in his own right, and joined us about a year and a half ago at the school, and is now the director of public programming, and has done a fabulous job of recruiting and attracting quality speakers like the one we have tonight. So to introduce our guest speaker, I want you to meet a young man that you're going to hear a lot about in the future, one of the talented young people that we are glad to have on the staff of the Clinton School. Would you welcome a native of South Carolina, a graduate of the University of Nebraska, Patrick Kennedy.
Thank you. I too would like to thank everyone for coming out tonight and want to welcome you to the Clinton School of Public Service. This is a treat to see all of you here, and I'm excited to have you all here and more in the future. I'd also like to give a special thanks to Dr. Thomas Bruce, our Associate Dean, who has been a strong advocate of holding conversations of global health here at the Clinton School. And under his leadership, we will continue to have more of these conversations discussing the intersections between global health and public service, I can assure. Thank you for all your help and guidance in this process. But tonight we're here to discuss an issue that is a pretty important issue and has received much publicity lately, and that is the threat of a global pandemic. Much of the conversations that you have seen as of recently has been about the avian influenza virus, also known as the H5N1 virus, that could potentially trigger a global pandemic and cause massive chaos and disrupt all aspects of life within the United States and around the world. Our speaker tonight continually emphasizes that whether it's the avian influenza or it is an emerging disease that we have yet found and it doesn't even exist yet, a global pandemic will in fact come. He equates it frequently to the hurricanes, that a hurricane will come. We don't know what shape it'll take, but it will come. In fact, our speaker recently said that if it is going to happen, it is not when it is going to happen. It is when, it is where, and it is how bad. So there really is no better person to talk about this issue tonight, about the threat of a global pandemic, than our speaker, Dr. Michael Osterholm. Now, to tell you just a little bit about Dr. Michael Osterholm, he is the director of the Center for Infectious Disease Research and Policy. He is the associate director of the Department of Homeland Security's National Center for Food Protection and Defense. He is a professor at the School of Public Health at the University of Minnesota. And in June of 2006, Secretary Michael Leavitt, Department of Health and Human Services, appointed Dr. Osterholm to the newly established National Science Advisory Board on Biosecurity. And in the past month of talking to global health experts throughout the state and throughout the nation, It said, Dr. Osterholm possesses two qualities, and that is courage and conviction. And that has been evident in the work he has done around the world. So as you can very well tell, we are very privileged to have Dr. Osterholm address the threat tonight. And please join me in welcoming Dr. Michael Osterholm.
Thank you, Patrick, for that very kind introduction. Senator, it's great to be here with you. In addition, Dr. Bruce, I too want to give my acknowledgement as someone who's been a long-term fan of the work you've done for many years. Dean Rutherford, thank you also. It's a real honor to be here in the throes of the Clinton Library and in the program here, given all that the President did in the area of public health while he was there. And I had the fortune to spend some of that time working in some of those programs, and I think it's great. And I don't want to diminish that, but I have to tell you, the person that I have the fondest and greatest love for of all public policy people probably is Senator Dale Bumpers and Betty Bumpers, who I've had the chance to work with in the area of immunizations for 20 years. And I have to tell you that it is an experience to spend time with Dale and Betty and work they've done, and they truly are real public health heroes. So while they're not here tonight, they're here in spirit, clearly, and it's great. Well, I'm here tonight to talk about something that no one wants to talk about, but everybody wants to talk about. And that's the issue of the concept of an influenza pandemic and what it might do. Let me at the very beginning set the record straight as a public health professional and how I will view this issue tonight and go from there. On 9/11 of 2000, 1 year before the 9/11 event, I published a book called Living Terrors, What America Needs to Know to Survive the Coming Bioterrorist Catastrophe. In that book, it was primarily about bioterrorism, including the use of anthrax, kind of like it was. But I also talked about the fact that the World Trade Center Tower and the Al-Qaeda, 1 year before it happened. If you'd asked me in that intervening year between 9/11 of 2000 and 2001 what the likelihood that that attack would occur, I probably would have told you, given my science background of risk, I don't know, 1 in 5,000 to 1 in 10,000 or something like that. Real. I am here to tell you tonight, and hopefully provide the supportive information why. The risk of an influenza pandemic is 1. It is going to happen. Unless you can somehow eliminate hurricanes, unless in Minnesota you can suddenly put a big baggie around our state and eliminate winters, you will not ever escape the next influenza pandemic. So at the outset, let me just dismiss any idea, is this real or not? Is this another Y2K or whatever? This is going to happen. The question, as Patrick framed it, is we just don't know when, we don't know which virus will cause it, and we don't know how bad it will be. But tonight I'll give you a sense of why we today are as vulnerable to an influenza pandemic as a society, as a world, as we may have been in our entire history of humankind. A very strong statement again, but let me share with you why I think that to be the case. Now, I have about 9,000 slides in my repertoire of slides, the last count. And if I had to get rid of all of them but keep one that I think really tells the story of where we're at today in the world, this is the slide. And I realize it may be hard for some of you to see. But what you have on the right vertical bar here is population in billions, and the left one is days to circumnavigate the globe, and this is the last 150 years. In the last 150 years, we haven't really changed a lot for the last 50 years what it took to get around the world. That first 100 years of that time period really made a big change from 1 year to literally, with the advent of the Boeing jet, we're talking now about 42 hours. What has not reflected in this bottom line is what goes around the world. Today, the global just-in-time economy is our Achilles heel. While it's our strength, it's our major vulnerability. I'm going to talk about that tonight in the context of influenza. Much of what we count on every day originated offshore somewhere. And anything that interrupts international trade and travel will interrupt quickly the global economy. On the other bar, you see the world population. Today, there are 6.5 billion people on the face of the earth, and the number grows quickly. Back in 1918, a time I'll talk about tonight relative to the previous pandemic, the world population was 1.8 billion. Today, 1 out of every 9 people who's ever lived since the caves is on the earth today. That's a remarkable concept. The point is that also has real implications for what a pandemic will do. Now, there's a lot of people who put going on with influenza and avian influenza, modern worldview of pandemic. You can't quite see this, but this is Chicken Little over in the left bar. This is We're All Going to Die, a bunch of tombstones. And we find ourselves as a society typically wanting to fit in either one. A couple months ago, I was on Oprah, and needless to say, my email was overrun after I was on there, literally thousands of emails. And they really divided into two camps. One camp is, why in the hell are you scaring us so badly? This is just, you are irresponsible. And the other side of it was saying, we're all going to die and you're not telling us the truth. Really, why aren't you leveling with us how bad this is going to be? And I guess this is a natural kind of reaction to any kind of news like this. In fact, ladies and gentlemen, the truth is in the middle. We're not all going to die. We'll get through the next pandemic just as any civilization has before us. But it's going to be tough. If you believe that it's not going to happen or you believe we're all going to die, you can go home, get your bottle right now, go to bed, and just write it off because there's nothing you can do. And that's not the case. There's much we can do. And what we need to understand is now's the time. And every day we waste to do more, and I'll talk about that do more later as we go through this. Now here's an example of why you might very well be quite confused. This is, what some would say is one of the prominent papers in the United States, the New York Times. This is the same science writer, the same editor for the science writer, the same newspaper on May 14th, Sunday, publishes a story above the fold that says, avian flu wanes in Asian nations at first hit hard. If you read that story, you would come away thinking, this was another Y2K. People kind of really blew this. It wasn't really all that important. 4 years later, same author, same journalist, writes a story, bird flu deaths in Indonesia raised concerns, talking about this cluster of cases we were just unfolding in Indonesia, and said, maybe this is it, maybe it's coming. Then, another story, human flu transfers may exceed reports suggesting a lot more is going on out there than we ever knew about. Same journalist, same newspaper. What does this mean? Today we're being whipped back and forth constantly about what do we really know or not know. Including our New York. It's not in depth. It doesn't really understand what's happening. And so tonight what I want to do is I'll tell you right now at the outset, and this may be a reason for a number of you to get up and leave. I know less about flu today than I did 10 years ago. When I was teaching my graduate students 10 years ago, I thought I knew a lot more about this topic. And the more we've learned, the more we realize, very humbly, how little we really know. And I'll try to share that with you tonight, what we really know, don't know, and what's a maybe. Now, the World Health Organization put out a document last October about 10 things you must know about pandemic influenza. And let me just say at the outset, at least from the perspective I come from, and some in the room may have some additional comments, but the WHO is really often considered to be one of the most conservative organizations we ever deal with. I mean, they typically are, if you want to have a nice conservative base, where by the conservative meaning, they never shy too far away into the future, etc. So take these comments on this light. Pandemic influenza is different from avian influenza, point one. I'll explain the difference tonight. There's a lot of confusion about avian influenza and what's human pandemic influenza. Second of all, influenza or pandemics are recurring events. Like earthquakes, hurricanes, and tsunamis, pandemics happen. And they will happen again. And that's an important concept in the sense of understanding what we have to prepare for. The world may be on the brink of another pandemic. I got to tell you, that's pretty strong language for the WHO to say we're on the brink of another pandemic. That was last October. All countries will be affected. Nobody's going to escape this one. This will be a worldwide event. Unlike a lot of catastrophic events, wars, natural disasters, typically are very regional in their nature, and temporally they tend to be rather short-lived, at least natural disasters. Widespread illness will occur. I'll comment on what widespread illness means. Medical supplies will be inadequate. I will lay out for you right now that our medical care system in this country will be no better during a pandemic than 1918. Now that seems very strong, and a lot of people negatively react to that. But I'll point out why that's the case. Modern medicine as we know it will not take place. Large number of deaths will occur. You'll see what those numbers mean. How are they related to economic and social disruption will be great. It's WHO saying this now. Every country must be prepared. I don't know what that quite means yet, but I'll tell you that it's, at least in spirit, correct. And finally, the WHO will alert the world when the pandemic threat increases. I'm not sure I have complete confidence in WHO that way. In this recent cluster in Indonesia, only 2 WHO investigators actually made it to the rural village of Sumatra in Indonesia. They were in essence escorted out pretty quickly for reasons that have to do with some communication skills. It was only because a very persistent Bloomberg news reporter from Hong Kong found that 3rd generation of cases, or we would never have known about that. So also don't think we have this elaborate surveillance system out there that's going to quickly respond to these things, because that's not the case. Now, I've added a couple of additional things you must know about pandemic influenza. Vaccine and antiviral drugs will have minimal impact in the pandemic if it occurs in the next several years. Why? Because we won't have vaccines and drugs. And I'll explain why that's the case. No quick fixes right now. And one of the things that I have the hardest time about dealing in Washington with is everything's about a quick fix just before it happens or after it happens. There aren't any quick fixes. Second of all, it's going to occur in waves. Pandemic influenza is a situation that occurs where once it emerges in the world, it has historically swept through the world in waves, meaning that it will go through a community in the spring, in an entire area of the world, and then it's somewhere else throughout the world at the same time in the early summer, and then it comes back again. And what's interesting about it, in 1890, the pandemic then, the 3rd wave, 16 months into the pandemic, was by far the worst one that killed the most people. In 1918, it was the 2nd wave that occurred in the fall of 1918, even though the 1st wave had occurred in the spring. In 1957 and 68, 2 pandemics were quite mild by all of our estimates. It was the 1st wave that was the most severe. We don't have a clue when to blow our wad. When do we take what limited resources we have and put them out there, because we don't know which wave is going to be the worst one? That's a lot of indecision at a time when we need really good decisions. Non-pharmaceutical interventions, quarantine, infection control, distancing will have limited impact. That's in part true because of the fact that with quarantine, with influenza, while it's often been stated you're infectious up to a day before, some of that occurs. But the point of it is, by the time we realize you have influenza, you'll have likely transmitted to a number of people. That's very different than with SARS, whereby your likelihood of transmitting wasn't really that high until about the 4th or 5th day of your illness. You were in the hospital often by then, and then on top of it, we were manipulating you in terms of your air source and so forth and made it worse. It's not easy to quarantine. We won't be able to do that. Infection control I'll come back to. Today, we will run out of masks and respirators overnight, and I'll give you the reason why. Social distancing, I don't know what this means. I mean, how do you keep people at arm's length away so that I don't breathe on you? Well, today we worry about that because social distancing works if it's only the first couple of feet, and sorry, Senator, but I've nailed you pretty largely already tonight here. If I realize I have flu on the way home tomorrow morning, I'll give you a call. But in addition, we now know that influenza also can be transmitted via the aerosol route, the idea that it can also move distances to the back of the room. And so it's not just only up close. And so I'll come back to this, but the idea of what can we do about it is, and we have to be honest with our public about what we know and what we don't know, because as soon as we tell them, do this or do this, and it doesn't work, and then we realize we kind of was wishful thinking, not based on data, we will have no credibility. And when we have no credibility, that's what leadership is all about in a time of a crisis. In terms of the other additional things, a global just-in-time economy prevents a unique state of vulnerability to a pandemic. I've had recent discussions lately with people like Tom Friedman and Secretary Bob Rubin, the Treasury Secretary under President Clinton, and they would all tell you exactly the same thing. I'll even come back to that in a minute. International governments will have limited resources to respond everywhere and to everything for 12 to 18 months. Secretary Mike Leavitt, Secretary of HHS, has been panned a bit recently because he's been going out in the community saying, you got to do a lot of this yourself. We're not going to come in here. I give the guy great credit for being just honest. It's not he's trying to cover his butt up front with a Katrina-like event. When you have a regional event, like a hurricane or an earthquake or a tsunami, you can have 47 other states send their resources temporarily to help out that area. You can, in fact, divert what was in that supply chain for the rest of the world temporarily to that area. When we're all in it together, every hamlet, every village, every town, every city, every county, every state, every region, every province, every country, we're all going to need it at the same time. There won't be people coming to assist you. Hope and despair are not strategies. Right now I see a whole lot of it. We hope and we despair. In fact, it would be like the issue right now, what if we could have foretold 1 month before Katrina happened, the levees would give way, this would all happen? we might very well have had hope and despair. But now we knew after it happened, we really responded. We did. But what could we have done if we had known just a little bit before? We've got to do that. Business continuity planning is not optional. You know, I'm an infectious disease epidemiologist by training. What the heck am I doing talking about business? I will submit tonight that as goes the private sector, will go our health. Because if we don't have food, if we don't have medical supplies, if we don't have a lot of the things that we count on every day in our lives, the health impact will be substantially greater. And finally, and this is the message that you have to completely believe, or you might as well go home now, we will get through it. Like every other previous catastrophe, we'll get through it. The question is how much collateral damage, how much direct damage is going to occur in the process, and what can we do about that now? Now, in terms of when does a pandemic occur? Pandemic influenza occurs when a bird virus, which is where the influenza virus normally resides, and I'll show you that in a moment, is finally capable of being transmitted by and to humans. It occurs when it's really adapted genetically, so now that bird virus is readily moved between humans. Second of all, it's genetically unique, so we don't have a lot of protection in our society, meaning that we haven't seen it before, and that it has some increase in virulence or ability to kill. We've met two of the three. What we are on the cusp of right now with H5N1, the strain in Asia and to some degree in Europe, is whether or not that will eventually make it so that it's readily transmitted between humans. And when that happens, as much as we talk about the birds right now, H5N1 is about the birds. Pandemic influenza in humans is not about the birds, it's about humans. The birds will become irrelevant. Pandemics have differed in terms of their population-specific mortality and cannot be characterized by a single risk predictive mode. There have been very different kinds of pandemics, and none of us can predict for you whether it will be a really severe one or a less severe one. I would submit today it doesn't have to be a very severe one to bring down the global economy. SARS killed 8,000, or affected 8,000 people, killed 800 people, but if you were in Toronto, if you were in Hong Kong, if you were in Singapore, you saw what happened to your economies. You saw what happened to the psyche of the people for 6 to 12 weeks. And now imagine that even a mild, and SARS would be considered a mild pandemic if it were to occur on a worldwide basis. Now, I mentioned earlier about influenza. Let me just quickly, for what I assume to be somewhat a lay audience, although I know we have a number of medical professionals here. This is where the reservoir of influenza exists. It's in wild aquatic birds. For those who are trivia nuts, wild aquatic birds emerged 150 million years ago. Poultry didn't emerge until about 100 million years ago. In that time period, these viruses set up very nicely in these wild aquatic birds. Occasionally, these viruses make their way to other bird species, including the domestic birds, where there's two types of influenza called high and low path. I won't go into that. One is much more severe. That still has not much significance for humans. It's very important to the world's production of poultry and other domestic aquatic birds. We know occasionally this can infect other animal species. For example, we didn't know that cats were really a very good recipient of the H5N1 virus until we fed dead H5-infected chickens to 46 Bengal tigers at the Bangkok Zoo, and they all died within 3 days. And 4 more died who hadn't any contact with the birds. They just had contact with the sick cats. Today, best we know, at least 46 different mammalian species are able to be infected by that virus. Now we see what we concern now is it gets closer to humans where we can have what we call the one-off transmissions, what's happening right now in Asia. I'll show you that in a moment, where basically only rarely does that virus finally infect a human, and almost never does that virus get transmitted on by a human to another human. Not yet fit. We know a concept called reassortment where it can get into pigs. Pigs are a universal recipient where they can be infected by bird viruses and human viruses, and sometimes they get together, they mix up there and create a third virus called a reassortment. That can cause a pandemic. Or what we're worried about now, and what we know about the 1918 virus, is it can also occur when there's just enough changes in that same virus, so essentially it's still a bird virus, but just has enough changes that finally it can transmit to humans by humans, and you have a pandemic. This is what we're worried about right now with H5N1. Now, in terms of understanding pandemics in history, they've been recorded since Hippocrates. The 1580 pandemic, so just so you don't think 1918 is the only severe one, is a classic example. It started in Asia and spread to Africa, Europe, and the Americas. In 6 weeks, once it got to what is today Turkey from Asia, it wiped through all of Europe in 6 weeks. Mortality was high. 9,000 of 80,000 residents in Rome died in 1 week. during that pandemic. In addition, some Spanish cities were described as nearly entirely depopulated by the disease. So bad influenza pandemics are not unique. We only remember 1918, but they do clearly go back to our history. Now, if you look, we've had 10 pandemics in the last 300 years. They range from 10 to 49 years between pandemics. They average about 24. You can do the math. Our last one was 1968-69. Now, I don't think we're due for a pandemic because this is not what we call normally distributed, meaning it's not like we expected. This is like having 3 100-year floods, in 10 years. It could be another 10 or 15 years before a pandemic hits, but it's going to. The reason we're so concerned today is because of this H5N1 Evolution virus in Asia. Now, to understand pandemics a little bit, let me just explain. In 1918-19, we now know this was caused by what's called H1N1, the hemagglutinin neuraminidase. I won't go into that beyond to say that those are very important parts of the virus, the components of them that help us identify them. It's like Mike Osterholm, Paul Peterson, that type of thing. The point being is we only grew this virus out recently because of CSI-like science, where we actually now extracted the genetic material out of tissue from people who died in 1918, found all the genes, went back and recreated the virus, which is a whole interesting story unto its own. But we know in 1918, 200 million to 1 billion people were infected, 50 to 100 million people died. You'll often hear a lower number, but there have been several recent efforts that really have redefined that. One was a group of medical geographers who went back country by country and determined clearly that probably closer to 100 million people died in 1918. It also killed a disproportionate number of healthy young adults. Most influenzas seasonally, the thing we see every season, which is the remnants of the previous pandemic, kills the very young and the very old, called the U-shaped curve. So even when a bad flu season occurs, it kind of is like all tides raise all boats, rising tides. The curves just get higher at either end. Along comes 1918 and it had a classic W-shaped curve, where the highest mortality was in healthy 20 to 35-year-olds, not at the either end of life experience. And I'll come back to that in a minute. We had some evidence why that might be occurring with studies that were done involving pregnant women. In 1918, in 13 different studies around the world, of all the women who were pregnant, 23 to 71% died with a median of about 55%. In one county in Minnesota, 38 of 42 women who were pregnant during the pandemic of influenza died. This is a hint to us because the way they died was, in fact, really their own body turning on themselves. If anyone thinks about the immune system of a healthy person, there really is not a much more precarious time than that of being pregnant. Because part of you is saying, this shouldn't be here. There's part of me that's not supposed to be there. And there's part of me that's saying, this is the most precious cargo I'll ever carry. And the immune system really is in a very different state during a pregnancy. And when that virus got in the middle of that, that created some real havoc. And I'll come back to that in one moment. 1957-58 came along, H5N1, the pandemic strain acquired now 3 genes from the avian influenza gene pool and wild ducks, reassorted with 5 other genes from the human. This is that reassortment. We think it occurred in a pig, we don't know. But this is almost the dumbed down version. It's not a new virus in the sense that it's all new, but yet it's got a lot of human in it. And in this pandemic, 60 to 70,000 people in the U.S. died. Along comes 1968-69 Hong Kong flu H3N2, which is now the remnant strain we still deal with. And whatever the next pandemic strain is, will likely become our seasonal flu till the next pandemic after that occurs. 2 genes from the duck reservoir, 6 genes from human virus, approximately 40,000 people died there. Well, let me just take a step back because I think that the current H5N1 situation should in fact be viewed through the lens of 1918. These 2 viruses are kissing cousins. Virologically, what we see clinically, and I'll explain a bit more about that. And I would urge all of you, if you haven't, if you really want to understand this, read this book, The Great Influenza by John Barry. It really is a masterpiece at helping to describe what really happened in 1918. Let me just paint a picture for you. This is a letter from Dr. Roy Grist, who was one of the physicians at one of the military training camps outside of Boston. He wrote this to his good friend Bert in the fall of 1918. It was discovered by Bert's family many years later in a trunk in the attic and subsequently published in the British Medical Journal in 1979. But Dr. Grist wrote, these men start with what appears to be an ordinary attack of a grip or influenza. And when brought to hospital, they rapidly develop the most vicious type of pneumonia that's ever been seen. A few hours later, you can begin to see cyanosis extending from their ears and spreading all over their face until it's hard to distinguish the colored men from the white. It's only a matter of a few hours then until death comes. It's horrible. One can stand to see 1, 2, or 20 men die, but to see those poor devils dropping like flies. We've been averaging about 100 deaths per day. Pneumonia means in about all cases, death. We have lost an outrageous number of nurses and doctors. It takes special trains to carry away the dead. For several days, there were no coffins, and the bodies piled up something fierce. It beats any sight they'd ever had in France after a battle. An extra long barracks has been vacated for the use of the morgue, and it would make any man sit up and take notice to walk down the long lines of dead soldiers, all dressed and laid out in double rows. Goodbye, old pal. God be with you till we meet again. Several very important points. These people didn't die typical flu deaths, which is what we often think of people getting secondary bacterial pneumonia, dying 8 to 10, 12 days later. These people died very quickly from what we believe today is a condition known as initially called the cytokine storm or immune reaction, leading to a type of overimmune response in the human. In addition, you notice the problems here. If anyone's a historian of World War I, you know the impact that influenza had. It was dramatic on the outcome of that war. This is, in fact, the same kind of clinical description we see for many of our patients today with H5N1. This curve, which unfortunately I know does not project well both by size and color, but let me just point out this is an example of what happened in Boston. What you have down here are the ages 0 to 9, 10 to 19, 20 to 29, 30 to 39, 40 to 49, 50 to 59, 60 to 69. In this graph here, you have the historic composite deaths in September, October, November from 1912 to 1916. And you have 100, 200, 300, 400, 500 per 100,000. Notice this U-shaped curve with the very high rates, higher rates, not high in the sense of what you'll see in a moment, in the very young and the very old. Along comes September and October of 1918. This curve is now 1,000, 2,000, 3,000, 4,000, 5,000. Tenfold what this one is. Notice what happens. You still have a tenfold increase from up to 300 to 3,000 in young children. But what's most dramatic is almost 6% of the residents of Boston between the ages of 18 and 30 died in the 2 months of September and October. That's pretty dramatic. Now that didn't play out like that in every city, hardly. But it was a point of what happened in many areas of the world, that this thing took off like this. The average age of H5N1 cases today in the deaths we've had so far is about 25.5 years. The average age of cases that died in the United States, our best guesstimate in 1918, was about 25 years. It's very dramatic similarities in terms of some of the issues we're seeing. Now, if one looks at the 1918, or the H5N1 experience, again, I'm sorry you can't see this, it's hard to keep these slides even updated. This is 228 WHO laboratory confirmed cases, 130 deaths, but you can see this concentration here. In the purple color is the cases of both human deaths and birds. You see the magenta color, which is actually where the birds have now also been shown to have H5N1. What's the relationship between cases in humans and what's going on? This slide, which depicts the current reported cases in humans, and I believe we are getting most of the cases. As much as I made a comment earlier about it took the Bloomberg reporter to find it, in the end, we're missing some, but we're not missing a lot. And our studies clearly show there's not a lot of asymptomatic or mild infection out there. We've got blood samples now from over 5,000 people in close contact to cases in the same environment, and either you get really sick or you just hardly ever get this infection. The point to make is this is in total cases, but what you see here is the percent that are lived, the percent that died. And what you see for January through June of 2006, and these case numbers are still coming in, the numbers just keep getting bigger and bigger seasonally. And what I believe that reflects is the amount of virus pressure in the bird population, and largely domestic birds in Asia. And we'll distinguish domestic birds in Asia from those of domestic birds in developed world countries in a moment. But the point being is that the more virus that's out there in birds, the more chances that humans have of actually coming in contact with it. This is not from sustained transmission. Really, we have evidence that people are getting infected easier now. It's just there's a lot more virus out there. Anytime I see a curve where 60% of the people are dying from the virus infection too, as an epidemiologist, that's not good. Now, in terms of what's the potential for H5N1 to result in the pandemic, I don't have time tonight to go into extensive detail, but there are many similarities between the 1918 pandemic strain and H5N1, that thing from 1918, and H5N1. Virologically, the way it grows in animals, etc., it's very, very similar. There's been this ongoing opportunity for this thing to what I call the ongoing genetic roulette table, for which to achieve this human-to-human transmission. In other words, there are so many birds out there today for this virus to basically have an opportunity to go through a genetic mutation that, in fact, we believe that this really does lend itself to an ongoing risk. It's not going to burn itself out, and I'll come back to that. And finally, I go to medical meetings and I hear the physicians get up and they'll say, well, you know, if it's going to happen, it would have happened by now. Ladies and gentlemen, this is part of what we don't understand about influenza. In the early 1960s, H5N1, another name for another flu virus, jumped from birds to horses. Anybody who's a horse lover knows today we immunize our horses against the influenza virus. We don't know why or how it jumped. It appeared to be a direct jump from birds to horses, and it's been a real problem. Suddenly, 3 years ago, this virus, still pretty much a bird virus in horses, jumped to dogs. And today we have a major problem with canine influenza out there from H5N1, and we don't know why did it take 30 years for that virus to jump from horses to dogs. We don't have a clue. The point being, H5N1 may not do it this year, next year, or next year, but I wouldn't want to bet that it's not going to do it. Why do I say that? Look at these numbers. You know, you're going to hear more about poultry in this country, and again, I have come back and said over and over again, poultry in this country will never be a significant part of the H5N1 risk to humans, ever. But in Asia, that's different, where we lack the biosecurity barn production. We lack the kind of ability to control wild bird, domestic bird content. And look how the world's changing. Just in China alone, in 1968, there were about 790 million people. The estimated production of hogs that year was about 5 million. The estimated production of poultry that year was about 12 million. Along comes 2004, and this is really true in many countries of Eastern Asia. Population now is 1.3 billion. Pigs are now produced at 508 million annual production level. And look at the poultry, 15 billion birds produced in 2004. And we see only a very limited change in this at all, even now with all the culling that's occurring. So imagine a forest that burns down once every 100 years because it takes 100 years to accumulate new trees. Imagine a forest that every night after a major forest fire suddenly gets 100 years worth of growth the next day. It can burn all over again, just cycle. We have so many new birds being produced every day in places like China, Indonesia, Vietnam, Thailand, that the point of the matter is that whether it's wild birds, domestic birds, it has ample opportunity to keep growing and growing and growing, and that's what we're seeing, and that's where it's going to mutate. Now, what will happen? No one can predict when, if, or where H5N1 virus will shift from an avian strain with incidental human infections like it is now to one where we have a genetically competent human transmitted agent. It could happen tonight. It could happen 3 years from now. We don't know. And it might not happen. We will have a pandemic, but it might not be this. Asia remains a genetic roulette table for H5N1 mutations. I have no doubt about that. I'm convinced that this is where there's such pressure. The first evidence of pandemic will be third-generation cases that are sustained. In Indonesia, we just baby dodged a bullet. We had a recent cluster over there where a woman, an older adult woman, transmitted to 6 people in her immediate family. Clear evidence of that because we actually have the viruses and can show that they continue to mutate, and we know when it happened. One of the people who actually became infected was her 10-year-old nephew. From the first virus isolates we have in him until he died, there's actually a series of mutations that occurred in his strain. Then, as he was dying, he transmitted that strain to his father, who, by the way, was not biologically related, it was by marriage. And his father got the mutated strain from his son, and then before he died, the virus continued to mutate even more. And then it ended. Were we lucky? We don't know. Next time, that may not be that false start. We just don't know. And with all the science training I have, and as an epidemiologist who's had 40-some hours of graduate statistics, you'd think I could give you a better answer than this. But it comes right down to what I know is, how would I tell you what the risk is? I wouldn't want to bet my family's life on H5N1 not becoming the next pandemic influenza strain. That's all I can tell you. I can't tell you what the risk is. I can't tell you what it is. I just wouldn't want to bet against this one. This one, I believe, has every possibility of doing it. Now, in terms of the bird issue, there's tremendous confusion about what's going on. Are wild birds doing this as domestic birds? It's both. Clearly, the migratory birds are moving this virus. These are bird flyways, where you can see, if you know how birds move seasonally from nesting grounds to wintering grounds, etc., there's a lot of overlap. Clearly, some of the movement in Europe occurred because we do know that certain poultry, infected poultry were moved. But a lot of it also has to do with migratory birds. Will it get to North America? I don't know. You have some experts in the room here who will probably tell you a lot more about that than I can. But I'll tell you one thing is I've been impressed in the past with the relative absence of Asian viruses in migratory birds in the Americas. And so we don't know, is there something there? But it doesn't really matter in a sense, because when I say it doesn't matter, there will never be the pressure of virus in the Americas because, in fact, the way we grow our modern poultry today is basically a very safe product in that it's in biosecurity barns, it's not exposed to the wild birds that might move it. Now, will organic chickens be a possible problem? You bet. On-range chickens. Will the idea of the backyard chicken flock be a problem? You bet. Because then they would have contact with the movement of wild birds. Now, also I might add, for those who are bird lovers, you know this already, but bird flyways are not highways. We have examples for you of actual bird species who over summer on nesting grounds up on the northern part of Canada that then go to southern South America in the winter. And one particular bird species which we have fairly good data on, 3 years ago, and 2 years ago, went on the Rocky Mountain Flyway 1 year, went because of weather patterns, pressure systems, and winds, went 180 miles off the Atlantic coast another year, and most recently went right down the Mississippi River Flyway in their movement. So even one bird species can move a lot of different locations. It makes it so that, in fact, you can't count on one bird species to tell you what's going on. Are wild birds really important with this issue? Not probably to humans, in the sense that the contact there is likely to be continued at domestic poultry. That's why I think Asia is so unique. But could it move it? It's sure possible. We just don't know. Now, in terms of what might happen with another pandemic, this is where you get really in trouble because people think you're inflating or you just never give them the right number. None of us know. We do assume that if H5N1 is the next one, like other pandemics, anywhere from 30 to 60% of people could become infected, 30 being probably on the very low end. If it's a 1968-like pandemic, 2 to 7.5 million deaths worldwide, that's a very mild pandemic. If it's a 1918-like pandemic, that's 180 to 360 million deaths. To give you a sense of what that means, HIV/AIDS in the last 30 years has killed about 28 million people in the world. That's real numbers. If it's the current H5N1 case fatality, we're talking about 1.6 billion deaths. Now, I got to tell you, none of us really believe, I think, would ever stay at that high mortality rate because for it to adapt to humans and be transmitted, it would reduce the case mortality rate. But reducing the virus from 60% to 30% would be a big drop. Well, 30%, my God, that's 15 times higher than 1918. It's a hard place to go and think about, but we don't know. We just don't know. But you can't say that couldn't or wouldn't happen. We don't know. In terms of what we have to look for in this country, these are the official numbers from the Department of Health and Human Services planning document looking at a moderate pandemic or a severe pandemic. Why do I think healthcare will not be that of modern healthcare, but of the 1918-like healthcare? Well, here's an example. If you look at these numbers, even for a moderate, we're still talking about 4 to 5 million people needing outpatient care, 865,000 even hospitalization. Any of you are aware of the IOM Institute of Medicine report that came out 2 weeks ago showing that we have diverted 500,000 people last year in this country were diverted from an emergency room at a time that they needed one, meaning that they were full. That's 1 every minute in this country. Our emergency rooms are so overstretched today. Well, if you look at ICU care, 1.4 million people would need intensive medicine care with 742,000 mechanical ventilators. A study that I did when I was serving as advisor to Secretary Thompson, we went back and looked at all the mechanical ventilators in the United States in all of our hospitals. There were approximately 105,000 such mechanical ventilators. On any one given day, 80,000 are in use. And during regular flu season, we get right up to 100,000. We have no excess capacity there whatsoever. But in the global just-in-time economy, I'm not sure it's the mechanical ventilators the problem. Your average hospital today has no more than 2 days of oxygen on hand. It's a just-in-time delivery product. And that's tied in very clearly to the petrochemical industry. When they're not operating, there won't be any oxygen. So I'm not sure which is worse, no mechanical ventilators or no oxygen. In terms of looking at responding to a pandemic, let me quickly close by looking at some prevention, patient treatment issues, populations, and medical systems response, and those non-pharmaceutical interventions that I talked about. Vaccine. Our current influenza vaccine reflects 1950s technology with one exception, one additional piece that we've added to it. So the same vaccine we used, made when I was using the slide rule in high school, is the same vaccine we virtually have today. On a worldwide basis, we only have the ability to make about 300 million, we call 15 microgram doses. That's the current dosage we use right now every flu season. That's it. That's the entire world capacity. That's all the pipes, that's all the plumbing, that's all the machines, that's all the plants we have. We're trying to buffer that up, but we're about to throw 10 million doses away from last year's flu season. Companies aren't investing in this because there's no money in it. Besides, it's such an old technology. Who's going to invest in 8-track tapes when we all know it's flash drives? The current research around H5N1 has been often misunderstood. I'm aware of at least 31 candidate H5N1 vaccines that are being tested. We can take the old strain, the strain of 6 months ago in humans or in birds, and make a vaccine for humans. But we also know that you need the new strain, the strain that causes the pandemic, to really have the best protection, which means you can't start making the vaccine really until you get that strain using our current technology. What's really problematic is we've done studies looking at how well the humans respond to the H5N1, and all the studies show we need at least 6 to 12 times as much antigen, meaning more than we currently use. And we can't grow this virus worth a darn in chicken eggs, which is where we grow it. Only 10 to 50% of yield compared to what we currently grow for flu virus vaccine. Bottom line is, our best guesstimate in the first year of a pandemic, we'll have enough vaccine to vaccinate 20 to 30 million people worldwide, and the vast majority of those people will be outside the United States because that's where the production capacity is. So don't count on vaccine in the first year of a pandemic to do anything for you. Second of all, if you look at the issue with oseltamivir treatment, or Tamiflu, which again has become the Cipro of the flu world, H5N1 and 1918 H1N1 caused very different disease than H3N2, the current seasonal flu. This is the cytokine storm, this acute respiratory distress syndrome. And we're doing a lot of work right now to understand, does this drug really work? We don't know if it works with H5N1. We have reason to think it could, and I surely would tell you we should be making as much as we can in stockpile, but we don't know. What if you have to give it on the very first day of infection, which it may be? What if you have to give it at least fourfold in dosage than it is now? The bottom line, though, is the same thing is true. Roche Pharmaceuticals, which has the licensing agreement to manufacture that, and now have sub-licensed this to any number of generic manufacturers. Our best guesstimate is, in the next 5 years, we can make enough Tamiflu for about 7% of the world's populations if we don't up the dose. If we up the dose, potentially fourfold, that means maybe we can produce enough for 1 to 2% of the world's population in the next 7 years. Point being is that this isn't going to do it. This isn't going to be the answer either. It may have some limited impact, but not much. In terms of other issues around the healthcare, who's going to come to work during a pandemic? You know, I sit here as a professional, but where I really sit here in front of you is I'm a father. My daughter will be chief resident of pediatrics at the University of Minnesota a year from now. She's going to be on the front lines without a vaccine, without drug, and she's probably going to run out of respiratory protective devices very quickly. 2 companies in this world now have a very large percentage, extremely high percentage of the world's market share of making the respirator masks that we need. And they're both operating at full capacity right now. They have no ability to bring on excess capacity from what they currently have. And because of litigation issues and because they don't see a long-term market, they're not really building new plants. We'll run out of those masks overnight. Trust me, we will. Then what are we going to do? I just served on an Institute of Medicine committee that looked at this issue, and we believe you need those masks. We know we're not going to have them. Are they going to go to work? Is our healthcare system going to show up? We saw in Toronto with SARS, despite the ability to have all that equipment available, because we had enough just because it was so limited of a hit, that by the 8th week of the SARS epidemic in Toronto, 25% of healthy healthcare workers wouldn't show up to work. I worry desperately about the healthcare system. Medical devices. Today, how many of you know that 80% of all the pharmaceutical products used in this country and 100% of the vaccines are made offshore or have major component pieces made offshore? I have been with the senior pharmaceutical leaders of this world, and they'll tell you they have no doubt the pharmaceutical industry will drop overnight because conditions offshore are not going to be any different here, and transportation will literally go down overnight and convince people will not move. Now, I'm not talking about drugs for influenza. I'm talking about cancer treatment. I'm talking about antibiotics. I'm talking about your heart drugs. We outsource all of our pharmaceutical industry today to parts of the world that are even more vulnerable to pandemics than we are. Now you understand why I think we're not going to have a healthcare system. If you don't have workers, you don't have high-tech equipment, and you don't have drugs, what do you have for a healthcare system today? One that's already stretched beyond the max. Corpse management. I believe that the ultimate indicator of how society will respond to flu is how we deal with our dead. I believe that in Katrina, as bad as Katrina was, and all those shots of the Superdome, what really took people over the edge was when they kept seeing those repeated shots of dead bodies laying there, disrespectfully discarded aside. Particularly one woman laying face down in the water with her wrist tied to a pole so she wouldn't float away with a black magic marker number on her back. Remember how they kept showing that? We now have data from the tsunami in Indonesia that how you deal with the dead is what sets the psyche of the population. Well, in 1968, in the last pandemic, the average time from a casket being made in this country until it was in the ground was 6 months. Today, the average time for a casket being made until it's in the ground is less than a month. And a number of the component pieces come from offshore. We're running out of caskets overnight. Today, our situation for using crematorium space is a just-in-time delivery system also. We will literally not be able to process our dead in any timely or respectful way. Now, some cities like Seattle have gotten very creative. Hopefully it's going to work. They've gone out and they've figured out where every indoor ice arena is in 60 miles of Seattle, and they're going to take them all over. And they're going to try to hold bodies in the ice arenas until they can process them. That is going to be a big issue. We've done virtually nothing to plan for corpse management in a meaningful way in this country, and that's what it's going to be locally. In terms of looking at other issues, food and water. In 1968, the last pandemic, when Green Giant canned a can of corn in Minnesota, or anywhere else in the United States, off that field, that can of corn sat in a warehouse in many instances for 6 to 12 months before it went out into commerce. Today, that can of corn is in commerce in 38 hours. And they're harvesting fields all over the world to make sure you have your cans of corn every day. That's true for the entire food system. Our friends here who are in the poultry industry can tell us about this little ability to have surge capacity or this idea of this just-in-time delivery. That's true with everything. Our group held a meeting in the Twin Cities this past February where we had companies representing some of the biggest in the world present to deal with this issue. Their annual revenues were almost $4 trillion, people who attended this meeting. Very senior people. We heard from every one of the oil refinery, energy exploration companies that said, if we lose 20 to 30% of our workers, we have to shut down our refineries, because not only do we have a just-in-time delivery system, we have just enough employee system. We can't safely run them. We heard it from the electric regeneration people, same thing. We heard it from the broadband people. Every one of the broadbands, the people who are the big pipes that move your internet, said, you know what, that big bubble of excess broadband we had after 1999 to 2001 run-up, that's gone. Nobody's invested since then. And while there is some excess broadband, getting and moving via the internet is going to be very different than you think if you suddenly swamp it with this idea that we're going to use it for our just-in-time delivery of information. Equipment parts, I could go on and on about this. This is where we have got to start to deal with planning, of which we've done very little. What are we going to do to assure that these critical products that we need are present? In terms of what shall we conclude a pandemic, imagine a 12 to 18-month global blizzard, mandatory or voluntary closings of national, state, or local borders. I just got back from a 10-day tour in Europe. I happened to be there. It coincided with the Romanians and their response. You may have heard in Bucharest 3 weeks ago when H5N1 chickens were found in the center part of Bucharest. They suddenly cordoned off with barbed wire and guns a 20-square block area, which was absolutely crazy. That quarantine lasted for several days before they realized that it was not necessary. Governments are going to have limited resources to respond. We really will be on our own in a very large way. But we need government for us to coordinate the very, very rare resources that need to be distributed nationally. We can't have every hospital in the country fighting for cancer drugs for their patients. We've got to have some equitable way of moving that. Even under the worst case scenario, though, I come back and tell you, we're going to get through it. We will get through it. I did ask Secretary Rubin in the talks we gave in London recently, I said, Bob, how are we ever going to restart the global just-in-time economy once it goes down? And he pondered and he pondered and he looked back and he said, you know, whoever figures that out will win the next Nobel Prize in economics. Nobody's ever thought about how do you restart the global economy once it goes down? In terms of economic implications, I've not seen or heard of any credible estimate of the economic impact because it's this domino effect. Everybody wants to do a one-off. It's the whole domino effect. If petroleum industry goes down, all the petrochemical companies go down. You can just begin to see the march. Up to 20 to 30% of workers at any one time will probably be out either because they're sick, their family members are sick. I've heard companies say, well, we'll give Tamiflu to all of our workers and we'll keep them in our compound of our plant. Who's going to stay there for 8 to 12 to 14 weeks if they've got their mother, their daughter, their wife dying at home? You know, they're not going to do that. Supply chains are going to collapse. Disproportionate number of deaths will occur among the 20 to 40-year-olds, which will adversely impact the workforce. And again, how do you restart the world global economy? Let me just close briefly and say it's not all just doom and gloom. There is a lot we can do. And I would urge you to go to our website, and I'll be happy to address this more in questions and answers. But we came up with a 10-point framework for pandemic planning at our center at the University of Minnesota. And this was really the hallmark of what we talked about at our summit meeting, what we worked on. What can you do in terms of emergency management plan and structure, employee health and safety, internal, external communication, security, your information system? What are you going to do? What can you do to back these up? In terms of the issues of supply chains, critical inputs and outputs, you know, I got to tell you, and I know I won't be popular in some circles here, but I don't really care if we sell any iPods during the pandemic. But I care a lot if we've got enough food, we've got enough safe water, and we've got enough medicines for our population. How do we figure out how to really maximize that ability? Public media relations, you think Katrina was a media issue? It's going to be amazing. We need real leaders that can, for months, be seen by the public as credible voices, just telling them the truth and getting them through it. Legal issues are amazing for the business world on this issue, government considerations. And then for some companies, it's going to be just a matter of survival. How do you get through it? Do you keep paying your employees for 12 months if you have no revenue? For most companies in this world, particularly small, medium-sized companies, they're bankrupt. What do they do? So let me conclude by just saying, it's not a matter of if, just when and where. We will have another pandemic. And even if it's a mild one, it's not H5N1, it's a SARS-like event, I still believe it's going to have tremendous economic impacts for 12 months or more. At a minimum, assume we'll not have a vaccine for the first 6 months, and I really believe much more of the first year, and then supplies will be limited. Even if a 1918-like scenario unfolds, 98 out of every 100 of us will still be around at the end of the pandemic. Some days I hope it's going to be a 1918-like pandemic scenario. How do we minimize the pain and suffering? We've got to think about that now. And finally, business continuity planning is not an option. Our businesses are going to be critical. That seems odd for a public health person to be saying, but it's the truth, because as goes our chlorine supply for our water, as goes our medicines, etc., is going to be how society goes. And again, I'd leave you with this website address up here, because a lot of the information I talked about what you can do about it is on that site. Thank you for spending the time with me tonight. I'm sure some of you will wish you probably hadn't come. But I promise you, since you're going to deal with this one day, hopefully this will be a head start in what is going to be our future. Thank you very much.
Terry Yamaguchi. Michael, that was very nice. I just wondered if you would comment on what the World Health Organization and some individuals now are talking about global strategies and ring containment of this. It doesn't seem like it's possible, but that's what everybody wants. At least some of the experts are talking about using the ring strategy, and you might explain that to the audience. Thank you.
Thank you, Terry. Some of you may know he's one of our leading physicians here in town. Thank you for that comment. We all want easy answers. And the thing I spend more time in Washington doing these days is trying to abuse people that knowledge that easy answers are going to work. Because, in fact, they won't. And I think the WHO has been somewhat captured by this. And just so I way back when we say what he's talking about is a group of modelers. Modeling is that very academic activity where you get together and you statistically kind of make a whole series of predictions about what might happen, and then you come up with an answer. And unfortunately, most models today can only capture a very little bit of what really happens or doesn't happen. And how do you put fear, compliance, non-compliance into a model? It's very hard to do. But some of the models have suggested you can get in early into an area like Indonesia or Thailand or China. You could take Tamiflu and dampen this and stop the pandemic from happening. And it's very, very attractive to people that want this easy answer. But once you start working through it, you realize there are so many holes to this thing, It'd be like trying to basically keep back a raging river with screen doors. First of all, you got to have early recognition. As I already pointed out, if you look at the situation we had in Turkey last January, and you look at the situation we just had in Indonesia, had they really been the real start of this thing, we would have been long past the time when it would have been effective because we got in so late. Second of all, we don't know what H5N1 and Tamiflu will do in that kind of setting. Third of all, the compliance issue among people today is one where I have anybody who's locally out there will tell you, they can't imagine how you would blanket the population and get them to really take the drug. You know that, in fact, in Indonesia, one of the biggest problems was the fact that the family members of the people that died thought it was the Tamiflu that killed them and refused to take Tamiflu when it was given to them. Their social, cultural ways of approaching it are very different than ours. Finally, last but not least, is the idea that when you look at human behavior and what you do in these models, it's often very different than what you'd expect. A good example, part of this model, is school closings. You know, if we close schools, we can really reduce contact between kids, which is the way the virus is accelerated. Well, let me just tell you, I've had many experiences of this at the State Health Department in Minnesota in my years there. Classic example, we had a large outbreak of meningitis in one of our communities a few years ago, where we suddenly had a group of one high school that all became ill. There were kids that died. It was a major traumatic event. Well, through our investigation, were able to quickly determine that there was a common social event that occurred outside of school late one night in which all of them had an opportunity to swap a lot of saliva. And we could link them all to that particular activity. Well, the point being, though, is we couldn't come out and say what they were doing completely. We tried to explain this, and we wanted to control the kids in the school setting where they wouldn't be swapping lots of saliva. Parents wouldn't hear it. We're going to close the schools. The next day, we have a picture of 14 high school students all sitting at the same McDonald's with one McDonald's cup, passing around all 14 of them. Now, you can't model that. So closing schools doesn't tell you anything about the behavior that will really occur. Somehow they made the assumption kids would all go home to stay in their beds, for 8 weeks or 10 weeks or 12 weeks. That's what these models do. So, Terry, the bottom line is I don't have any faith in these models. I don't believe, I think they're academic exercises that are really not helpful. And what they do is they divert us off the fact we just got to bear it and realize if this thing emerges in some place, it's going to happen. Last but not least, think of this. If we do have an emergence of H5N1 in some country, and they do call in the world's resources quickly, that place will become the biggest black hole of the world. It will have automatic economic sanction in the sense that nobody will trade or travel there. And we've dampened it. Well, there's not just one immaculate conception conversion of this virus. Once the pandemic happens, it happens, but there could be a second or a third. What country the second time up is going to be willing to say, yep, come on in? Because they just saw what happened to the first country. So I don't have any belief this will work at all. Yes?
Hi, I'm Jim Freeman, pastor of a church here in Little Rock, and I'm curious as to what you might see a role for communities of faith being now on this side of the coming pandemic, and when it happens, if you see a meaningful role for communities of faith.
I think that communities of faith are going to be a very critical part of the response to this pandemic. Because it's one thing that I think as a world we today live in, faith is one of the things that's going to be in the shortest commodity during the pandemic. It's people having faith in something, anything, not just their God. And I think that how you handle families in that hour of stress where they may lose multiple family members, where you won't be able to have the church services for the normal grieving process. As you and I both know, funerals are about the final interment of the dead, but it's not as much about the grieving process for the living. Who's going to go to funerals during the middle of a pandemic, even if you could have them? So, we've got a lot of need for very creative ideas of how we're going to respond to this issue. I think the second part of that whole issue is that in terms of communities of faith, being able to, as a group, come together and support reasonable government issues. In other words, there's going to be this divisiveness that's going to occur. I'm convinced of it. You're not doing the right thing, you're doing the right thing. And I think that you can be a very important stabilizing force just like that. And I have gone back and begun to examine what roles the communities of faith played during our World War II and World War I time period. And they played major roles. They were, in many instances in the community, the bedrock of that ongoing support and so forth. And we don't think about that today. And so I would urge you to. I have one last piece on that, though. It's a piece that's an addendum, and I hope you take this in the way. Get rid of the common cup. If there's one thing in the community on every give flu season that I worry about, it's the common cup. Why we haven't outlawed that years ago, I don't know. Then if you want to swap germs in a community, there's no better way than to have a Sunday common cup. Sorry, I mean, it's true. I don't want to ruin your lives, but it's true. Yes.
Gary Wheeler, one of the bad experiences we had recently was this rollout of the smallpox vaccine. We have a lot of the Sanofi Pasteur vaccine that's owned right now by the government. It's being bought up as quickly as it's produced, which has limited efficacy, but potentially might reduce pain and suffering by potentially reducing mortality, even if it doesn't prevent infection. Is there any reason we're not going ahead and rolling that out in the groups of people that we've spent a lot of time identifying that are our target first shot ahead with immunizations?
Let me break that down into two parts. I'll answer your second part first and the first part. What Gary is talking about is that today there's been this idea, why not just make an H5N1 vaccine now? That won't be perfectly a match to whatever the strain would be. And let's just start vaccinating people with it so that there might be some protection, meaning that in fact it won't be perfect, but it'll at least give us some protection up front. And that's a great idea. And frankly, if I had a choice between that vaccine, one dose of it, and Tamiflu at the time of illness, I'd take a dose of vaccine right now. There's one major catch to that. Again, we only have a limited capacity to make flu vaccine. And so are you going to get rid of seasonal flu vaccine production to make H5N1? And then you're still going to be for a limited part of the world. And one of the things that I have a very hard time with right now about our American approach, and I must say that, I watched public policy in action in its finest sense, and Senator, you can identify with this, I'm sure, last year. The president comes out and says, this is a very important issue last fall. We need $7.1 billion, most of it going into new vaccine development, which is really a drop in the bucket. Senator Frisk comes out, a Senate Majority Leader, same party, and says, we need a Manhattan Project. This is really critical. And in December, during the final budget negotiations, it was the House Republicans that gutted that and basically only gave the president half as much as he asked for. It wasn't a partisan issue. You can't even say it was about Democrats versus Republicans. It was people who had different ideologies about what we should be doing and not doing or really believing it was a problem. And so we're not furthering our vaccine stuff much at all. I mean, we're nibbling at the edges right now. And so I think the question, Gary, really comes back to then is, are we going to take the seasonal flu vaccine, take it off the shelf and start this, and how much could we really do? And what if H5N1 isn't it? The second piece is, we're not going to make a lot of new vaccine. No drug company is going to invest billions and billions into a new vaccine until we have a new vaccine made, meaning we're going to get out of chicken eggs, we're going to make it in cell culture, we're going to do something else. And we see only limited movement that way because, again, we're throwing away 10 million doses of this year's vaccine that people didn't use with that limited amount we had. So until we have a sea change. Now, I do have a recommendation on this, and I just want to say that I didn't really cover this, so I don't want to catch you by surprise, but there is a whole other body of research that says when we do vaccine for flu right now, we grow the whole virus up in a chicken egg. We basically take out the part that kills the chicken and we attenuate it or do it. And then we cut that up and that's what we give you. There's a whole other new group saying, well, let's not grow it in chicken eggs because that's so limiting. Let's grow it in cell culture where we make more modern vaccines. But there's even a third group out here working on what we call a universal influenza vaccine, which is to take the flu virus apart and figure out what are the parts in it that are stable that we could possibly make the antibody to well in advance of the flu that could maybe capture H3, H5, H7, H whatever, okay? I don't know if this is going to work, but I've talked to a lot of them who are really working on this, and I think it's a chance. What we need right now is a world leader somewhere to say, as was said on May 23rd, 1961, we're going to the moon because we're Americans and we're going because it's tough and it's what we should do. We need a world leader that says, you know what, pandemic flu should come off the table. And it could, if we could come up with a new vaccine that could be developed and made in advance of a pandemic, and for which there was world capacity to make it and distribute it. Think about if we have enough vaccine for the United States. What if we really did? We'd still be screwed. Because if the rest of the global economy goes down, all the things we count on are still gone. The cancer drugs. We'll still have a lot of people dying of cancer because they won't get their cancer drugs. We'll still have a lot of people dying from infections because we won't get our antibiotics. We'll still have a lot of all these things happening. So we have a need to care about the world. And so we need an international vaccine. And we do make those decisions. Now I know Little Rock is a little different because of a recent event, but the point I made is today you want to look around the United States, and I'll tell you, some of the most well-funded fire departments in this country today are international airports. In Minneapolis, St. Paul has one of the best-funded fire departments in the entire state. We have not had a plane crash at that very busy airport since its inception in the 1930s. We've had 2 planes go down in South Minneapolis in the 50s. Both of them were covered by the Minneapolis Fire Department. But we pay every day for all those trucks and people because we believe if it should happen even once, we got to have them there. We need to think of flu vaccine like that. If we could take pandemic flu off the table by willing to vaccinate the world in advance of a pandemic, the economic return is astronomical. But we don't have that leadership, not just in this country, but anywhere in the world. We've not seen it yet. You know, the Gates Foundation has not gotten the flu yet. We're trying. I'm working on it. Trust me. Trust me. So, other questions? Oh, we'll ask you some. Let me answer the second piece of your question. Smallpox vaccine. He was talking about the trying to vaccinate healthcare workers. I have to tell you, I think that's still a very important issue. One of the most memorable moments in my life, by far, I had the good fortune to serve as an advisor to King Hussein of Jordan for 5 years before he died. 3 weeks before he died, I got an emergency message in Minneapolis saying the king needed to see me right away. And what that meant usually was the next couple of weeks. No, right away. This was 9 o'clock in the morning. By 2 o'clock that afternoon, I was on a plane for London, where at that time he was at his estate Ascot outside of London. And I arrived in London the next morning and was whisked off to the house. I still had the same clothes on I went to work with the health department. And normally when I would see him, you know, it'd be sometime in the afternoon, I'd go back and sleep or something like this. He met me as soon as I got to Ascot. And for the next 7 hours, he just peppered me about smallpox. And I knew he knew something. And I didn't know what it was, but he asked me a lot of questions. A week later, he wrote a very famous letter. A letter that dismissed his brother as the regent, heir apparent, and appointed his son, the prince, to be the regent or the new king. And he talked about how some of his family had mistreated Queen Nora. But most of it was about a dying man who also talked about how he worried more than anything about the future. And how he wasn't as worried about war as he was about terrorism. All the things that terrorism worried about the most was biological agents. And then he went off in this long thing of smallpox. He knew something. And I'm not saying it was a rock. And to this day, I believe that there is a potential for smallpox to return out there. And if it returns, all I think we have to do is have people prepared to initially confront it in the sense of saying, because what will happen is the first night there's smallpox reported anywhere in the world, every emergency room will have thousands of people coming in with rash illnesses thinking they have smallpox. And we just need to have the staff. So we still need to deal with smallpox. I believe it's not done yet. But it will never be with flu, it's ever. Question? Yes.
Having an influenza vaccine, we've known the genome of H5N1 for nearly 5 years. And we made a recombinant vaccine 3 years ago, and we produced enough recombinant vaccine to cover the United States and wherever else. And it wasn't done because of a lack of leadership in our federal government, in our Department of Health and Human Services, and wherever else, including the drug companies. Why did that happen?
Well, first of all, what you're talking about here is recombinant vaccines, where you actually make the vaccine using basically cell cultures, or more specific, you can actually put pieces of the virus genetic material into another vector or another virus, another bacteria grow. And this you can make a lot more of it. One of the problems has been is that, again, there is no market. So the drug companies are saying, if you're willing to buy it, I'll make it, I'll develop thing. I mean, why go out and build a whole new plant that will take years to make if one day I can't sell it? That's their issue. And frankly, from a business standpoint, that's a fair point. The second point of it is this virus continues to change. We now are actually, we dumped the vaccine that we were making of 18 months ago in favor of a new vaccine 6 months ago because it had changed that much in just that time period. And so people are saying, unless you're prepared to use it right now, and this is the vaccine you need, which one would you use? And it's like seasonal flu vaccine, you know, which one are you going to use every year? And so I think that the point being is, well, I can tell you that's the argument. I mean, that's exactly the argument, is why they say, which one are you going to use?
You can make a deal with common vaccine in 3 months.
Right, but every time the 3 months is up, are you going to use it right away, or are you going to wait until you get closer to the pandemic? And that's what they're doing. So, well, that's an example of where's the economics behind any of this. I would suggest to you that putting, you know, a couple $2 billion into the flu vaccine right now is one of the most underappreciated and underfunded investments that we as a civilization could make in terms of trying to deal with what's going to be one hell of a problem. Yes?
Jay Victor, I'm a cardiologist. I read a novel a few months ago, maybe, about somebody going to China and taking blood and spreading the virus around. I don't remember what it was. Now, with all this talk about H5N1 and related viruses, and I noted that you've served on bioterrorism councils, are you concerned about that at all? I know you're deviating from the main...
Am I concerned about this becoming a bioterrorist agent?
Yeah.
Not really, only in the sense is that we still don't know what it's going to take to make it a human-to-human transmitted agent. Now, someone could clearly work on that and try to make it one, but we have some research going on in the federal government in that regard. But it would take an exorbitant amount of expertise to manipulate this virus to the point of where you actually made it into a human pathogen and let it loose. So it surely could happen. You know, as Patrick introduced me, I'm now on the National Science Advisory Board of Biosecurity, which is this newly formed group to look at just that issue. Are we funding research today with just one slight movement of the switch could go from very good to very bad? And we are. There's a lot of things we do today that technologically we've given people who might want to do bad things a lot of tools to work with. This is one I think would be harder to do, but I clearly think it's on the radar screen we have to be cognizant. I'm not aware of anybody who has yet been accused of or thought of trying to enhance this particular flu virus. I think it hasn't hit the novel. I mean, it's not hit that stage yet. Yes, sir. You're on.
Dennis Burrow. In the same sense, we know that we're selecting out bacteria with the use of antibiotics and becoming immune to certain antibiotics and making a stronger strain. And we also know that if you had measles, mumps as a child, you had better immunity by having had the disease and stimulating your immune system that way than by immunization. Are we creating a weaker overall herd immunity by our immunization programs?
Right now, I'm absolutely convinced that there are some downsides to immunization. One is just what you just said, in the sense that the best protection you can have is from natural infection. But you pay a hell of a price to do that. And when you look at the number of people who had to die, the number of people who had severe illnesses, the number of people who had that infection but then died from something else as a complication of that infection is so high that there is no doubt in my mind that immunizations is one of the very best things we've ever done as a society. And so I think there is a price on the backside of it. And I watch this right now with the situation we've just had with the mumps outbreak around the country. That clearly was a situation where we had some people who didn't have enough immunity from their one dose of vaccine 20 years ago, and they hadn't had 2 doses yet. They'd had some waning immunity. But when you think of all the mumps cases we've prevented over the last 15 years, there is no doubt that one of the most single cost-effective, single best thing we've ever done for the world is vaccines. And that's why I congratulate the Gates Group. And Richard Jacobson, who's in the audience here with Jacobson in the audience with us today, is one of the premier leaders in the world in vaccines and children's vaccines in general. And I think, you know, what he's done in the emergency room and the intensive care units is remarkable. But what he's done to save lives by his policy work, his ability to get money saved a hell of a lot more lives than what you've probably done in direct patient care. I don't know if you'd agree with that or not, but you've saved a lot. Yes, in the back.
With all
You're on.
With all the attention right now being paid to avian flu, are we neglecting perhaps the risk from other emerging diseases, perhaps a mutated Marburg virus or a hantavirus?
If one only understood how thin the public health veneer is in this world in terms of resources, and why we hope groups like the Gates Foundation can add to this ability to be able to respond, I think they'd be very shocked. Many states today, I would be interested in the state of Arkansas, I'd be willing to bet that much of the resources you have for preventing infectious disease in this state are very tenuous, and many of them are fully dependent on federal resources that right now we're seeing decreasing, not going up, decreasing. CDC has taken 2 year-to-year consecutive real cuts, not just artificial cuts in their budget. And so I think that you're right. I mean, public health is public health, that's it. At the same time, I would say that of all the threats that I see before us, and I'm not just a flu guy, I mean, I deal with the plethora of infectious agents out there and deal with a lot of issues out there. There is nothing that comes close to the ability to change the world fundamentally and long-term than pandemic influenza. I mean, why did Gutenberg invent the printing press? Because all the monks were dying of plague, and there was nobody there to rewrite the scrolls of history. I mean, you look back in history, many of our major events occurred around the impact of infectious disease. Well, if you want to see what's going to rewrite the global just-in-time economy at a huge cost to us in society today, watch pandemic flu. That's why I don't think we can put enough into it right now in terms of what it will do.
All right. Just a couple more questions.
Richard.
Okay, Mike, I want to thank you first for coming. I'm going to sleep really well tonight. But I want to ask you a question. I mean, let's be on the stage, and you predict if you could do 5 things now, and we're going to make money not an issue. We're going to let you be the global leader. We're going to let you have all the resources that you need. What does the world need to do for pandemic flu?
First thing is, it's all predicated on time. Money's not an issue, it's time. I don't know how much time we have. It could be tonight. It could be next year. It could be 3 years from now. It could be 5 years from now. I don't think it's going to be 10 years from now. And I wrote an article in Foreign Affairs that was published a year ago this week, in which I actually laid out this scenario. What if it happened tonight? What if it was a year from now? And what was 10 years from now? What could or should we do? And almost nothing that I talked about that could be done in a year was done. We keep waiting and waiting and waiting. What I would do now is I would jumpstart this vaccine issue. I would make this a truly a Manhattan-like project. And Manhattan projects, many people don't understand. They think Manhattan projects have to do about the scientists. The scientists played a role in Manhattan projects, but if any of them really are a student of history, it was about management. It was about making every piece fit together at the right time, at the right place, right when you needed it. And what we need to do is that with vaccine, we have to understand world production is there. How many times have you heard anybody in this country talk about we got to get a vaccine for the rest of the world? Never thinking that if we don't, the global just-in-time economy will crash and will still be at this very, very high risk of all these problems. So that's the first thing. The second thing I would do is I would continue what we've started with the business community. In the next week, one of the single largest, I can't give it away, largest consulting firm in the world is going to send a letter out, the CEO, to the CEOs of more than 14,000 of its clients, saying you must have a business planning pandemic preparedness activity in place right now. And it must meet these things. We've got to support the private sector's ability to really work through this issue. I think that's going to be key. The third thing is our healthcare system. We've got to just understand our hospitals are not going to be important during a pandemic. They will be so overwhelmed so quickly, most care is going to be given outside a hospital. We're going to try to preserve the hospitals, I believe, for what is still going to be heart attacks, babies being born, patients who have other severe illnesses. That's going to be the case. We need to set up that dual system now. The fourth thing, I would get creative like Seattle. Every community has to figure out what they're going to do if 3 to 4% of their population dies in 3 months. What are you going to do? And make the real honest assumptions about what that means. And I think the final piece that I would really put together is we have to start understanding now the psychology what this is about. When I say understanding, I know that's a hard thing, but we're not preparing healthcare workers for this. We're not preparing critical infrastructure workers for this. We're not thinking through that. We just did a survey in Minnesota recently. When I was state epidemiologist, we used the National Guard often. You know, when I mentioned that meningitis outbreak, thank God we had them. The logistic support of the National Guard was incredible. We just did this survey where we found right now that about 30-some% of our National Guard in Minnesota either deployed in Iraq or Afghanistan. Of the remaining people who are there, we have so recruited over recent years, fire, police, and critical infrastructure workers, that they now make up another 30% of the National Guard. So if we pull them out of their communities to go to the National Guard, what have we done? You know, we've robbed Peter to pay Paul. What means we have this razor-thin surge capacity, really, even in our National Guard. We don't have anything. And so I think that's part of what we have to we have to do that analysis now. What do we really have to get through? What is it? So I think those are the things I would do and just keep getting the message home to the public that this is real. And that's not popular. You know, there are nights I got to tell you, I go home and, you know, I think to myself, you know, I got shot from the front today, I got shot from the back, and even a couple times shot from the side. You know, why do this? But, you know, I can't stand the thought of not doing this because I know one day this is going to happen. And I just have to think about my daughter, you know, on that front line and knowing that I didn't do it. So I think that's the other part. We got to get people who are willing to risk it and talk about these things and tell it like it is. Yes, right? You got to think of it. Go ahead. No, there's no mic up here. You need a mic. Okay, sure. There was something.
Amy Stewart. It strikes me that what you've really been talking about may boil down to an ability to make this patriotic, like what Roosevelt did in World War II. That what our government has to do is first figure out a way to make everybody care about making everybody get through this. That may mean nationalizing manufacturing capacities. It may, but more importantly, you've said that we can't expect the federal government to be able to handle this once it happened. But it seems to me what the federal government can do is put structures in place that are psychological, emotional, moral structures, not religious structures. But by moral, I mean things like, do we have somebody who is planning now for how we allocate scarce resources? Scarce resources in the sense that if we know that 20 to 40-year-olds are likely to be the target, have we figured out how to make sure that not just city by city or town by town, but nationally everybody recognizes that we need to make a decision that the people, to the extent that there are limited resources available, they go to the 20 to 40-year-olds, so that there isn't favoritism. There isn't, in one city we give it to whoever's around, and in another city we give it to the old people, and in another, you know. What the real issues are need to be planned for. Then it can be carried out at a local level. But another example is, what do we do about problems with illegal aliens? For instance, we look at the Delmarva Peninsula, and we say we have something like 16 different languages being spoken in the poultry processing operations in the Delmarva Peninsula. Now, we can assume that every one of the people, we can take it at face value that every one of the people who actually work in those processing plants are legal aliens, because they have to be, they have to have some papers. I'm going to assume that they're legitimate papers. But we can also fairly assume that half the people in their households are not legal. What do we do about the 16 different languages that we need to speak to get the message out to those people when the panic hits? Because if we don't get the message out to those people so that they don't do the things that we need in order to control the spread of the virus, they're going to be the ones who are spreading it.
Yeah. Well, you raised enough issues here to take us to tomorrow morning. Let me first of all just hopefully put in perspective your concern about 16 languages spoken at the Delmarva Peninsula. Last year, we needed 68 different languages interpreted at Hennepin County Medical Center, County Hospital, Minneapolis, the land of Lake Wobegon, to provide medical care. 68 languages. So that would be an easy one for us. I think the point being, and I don't worry much about illegal aliens, whatever you call them, relative to when this happens. There's nothing that they're going to do or not do that the rest of us are going to do that's going to make this worse. I mean, I think it's about getting through it. Maybe they'll show up to work, and in the sense, who's going to keep our food supply going, maybe that's important. I think the point you raise, though, let me just come back and say, when we had this summit in Minneapolis, we had the ability to actually survey people in the audience. And again, these were very high-level senior executives from these major companies. The one overriding answer that we found was up to 80% of them believe strongly or believe that one of the biggest problems they're going to have is the government was going to get in the way during the pandemic, not help it, but get in the way. And granted, I was coming off of Katrina, etc. I think we have a real lack of confidence today in government in general, which, given that I'm sitting in the Clinton School of Public Service, that is a very hard thing to say. But I think it's true. I worry about that. Who will be our credible leaders that will be believable, that will get people through? And I think that kind of leadership is going to be every bit as critical as any scientific leadership, anything else, the people who will get us through. And I don't know how to make that. I'm out of my league on this issue. I don't know how to do it. I just know we need it. And I think that's the thing. The other thing I think with society today is that I see far too much of this. It's about me, it's about me, it's about me. What are you going to give me? I mean, frankly, we're getting the kind of government we deserve because this is what we asked for. You know, this is what we continue to support. So the fact that we are going to spend a week debating whether or not we should burn flags or not, which I don't want to diminish that, but we've got some real serious issues before us that are not getting debated, I think is another issue. But I think that's part of the system we've got to realize is reality. I mean, I can't tell you how hard it was to watch the Republican caucus dissolve over funding flu vaccine in last December. I mean, that was, you know, it would have been easier if it had been a partisan argument. At least you could have taken a side somewhere. But it was the White House couldn't convince their own House leadership to go for this. So it said there was a disconnect somewhere. So I think that part of it is I don't know enough to know, but I just know that right now I worry there's a lack of leadership across society. And this is going to be one outcome of a lack of planning and preparedness. But it's not just the United States. Let me just point out, any other country could step up too. And the United States has done more on this than any other country. Without a doubt, they've done more. But the rest of the world's in the same position. They're not stepping up to it. So I don't know what your answer is for that one, but I know it's an important question. I know it's an important issue. That's where schools of public service and leadership need a lot more. I'm just a poor Iowa farm boy.
Well, don't forget rationing care. We're going to come to that. Who's going to run it?
Rationing care, I think we will, but I think that'll be a little bit easier in the sense that it'll be so clear that we won't have care to give. Meaning that, you know, what I'm worried about is how are we going to get the recovered truck driver who had flu, who's lost 2 family members, and now says, you know what, I can't drive, I don't want to drive, but I want to go help. And we're going to let them go in one of these community, quote-unquote, hospitals and work all day, 18 hours a day, because he's now protected. He can walk in the face of the lion and not worry about it. We have a system to do that. I worry about the first ventilator cases. You know, we deal with end-of-life issues, and as we saw in the last couple of years, they can be pretty nasty. Well, never one of those end-of-life issues was ever about allocation of equipment. They were all about whether or not we should pull the plug, as if there were other plugs around, it didn't matter. Now imagine we don't have any more ventilators, and there is a 77-year-old person who is in end of life, who is basically, for reasons of dementia, whatever, for the last 7 months, has been totally non-responsive, and we got a 28-year-old guy coming in, he's crashing. And somebody finally says, pull it, give it. We've never done that before. The ethical issues around that are going to be amazing. And so I think that's one of the few, I think. The other one's going to be the drug issue. When I say, you know, who's going to get what drugs? I don't want to be in the position when only 5 to 12% or 15% of people can get the drug that they desperately need and others can't. That part. That'll be tough. But those won't be as many as the rationing care of just all the sick people. What are they going to get? They're going to go to a place where they're going to have a cot, maybe, something like that.
With antibiotics,
Antibiotics would be in trouble. Yeah. The hospital doesn't go quickly. We'll go to the community very quickly. They'll be overwhelmed.
Okay, thank you.
Thank you.
I'd like to thank
Thank you.